Thank you very much for that. I want to say thank you very much for inviting me, and I wish that I was there in Manila. I just was unable to attend due to work commitments. I want to thank particularly Balash, who invited me, but Balash and all the Oncotherm team. I'm new to the world of electro-hypothermia. I got my first machine and started using it in January last year. So my experience is limited compared to all the other speakers. And so thank you for asking me to share my experience. First of all, I will say that obtaining the machine and getting to the machine into the United Kingdom, which has very stringent regulatory procedures, I was greatly helped by the Oncotherm team, who've been fantastic to work with every single day. They are very responsive and very helpful, and I would strongly recommend to anyone that they should work with them. So I'm more experienced in treating glioblastoma. That's what I've been doing for many years, and I've been running lots of clinical trials. It's a very challenging area. I work at UCL, but also part of the hospital. So you can see there's a picture of the hospital there, just a modern hospital in London, and there's a picture of our outpatient treatment centre. And there's also a picture of our Cancer Institute, where I have a small laboratory and a dedicated group of postdocs who work just on glioblastoma research. I want to just talk about some of my thoughts about glioblastoma and give some perspective of it, which might help people when they're planning treatments and trials. I was going to give it some discussions around trials I've been involved with and run, and then talk about the clinical trials that are in development and what we're actually going to do with the Oncotherm device, which I'm very excited about. So when we think about glioblastoma, it's a primary brain tumor. So it's not spread to the brain, it started in there. It affects 3,000 people a year in the United Kingdom, which has a population of 65 million people. The survival curve is shown here. It's actually not representative of the real survival curve. This is actually the survival curve when people have radiotherapy plus chemotherapy. And so this is only the fittest patients. We've looked at our data and published it from our multidisciplinary team. And looking at the last 500 patients, the average survival is actually only 9 months. So it's a really shocking disease. Patients generally present, they can be any age, most commonly around late 50s, early 60s. They generally present with either a seizure or they have developed some weakness. A lot of them present through casualties. They get an MRI and they can see there that it's a glioblastoma. They then go for surgery, and they generally go straight for surgery. They don't go to oncology first to discuss what might happen. And the surgeon takes a biopsy to confirm the diagnosis, or they take as much of the tumor out as they can. But surgery has a 0 cure rate on its own. And I think that's important to remember. There was a surgeon in the 1920s and 30s who treated glioblastoma by cutting out half of the brain. Obviously, this had a devastating effect on the patients, and it didn't cure any of the patients from the glioblastoma. So even if you go as far as cutting out half of the brain, you're still not going to cure this disease because it's a diffuse disease that dots around the brain. So following surgery, people go on to have radiotherapy for 6 weeks with chemotherapy, and the chemotherapy is called temozolomide. They then go on to 6 months of further chemotherapy. They get recurrent disease, and then very short after that, they die. And it's something that happens over and over again. So we do need to find better treatments for this patient group. Thinking about the disease, this is one patient, and what you can see here that they have 3 different regions of tumor, and at post-mortem, the different regions of tumor were removed. And when they were looked at under the microscope, they were seen as that part of the tumor was astrocytoma grade 2, part of it was glioblastoma grade 4 disease, and part of it was gliosarcoma, which is also an aggressive form of glioblastoma, and that's grade 4 disease. So it's quite a heterogeneous disease. But it does give us ideas about the low-grade tumors and high-grade tumors and our definitions of them, that they're quite blurred. So we tend to focus our treatments on glioblastoma patients, not treatments, our trials on glioblastoma patients, because we get the outcomes much quicker. So we can see how it affects the disease much quicker. But once we have treatments for grade 4 patients, glioblastoma patients, we know that they'll be applicable to the lower grade tumors. This is just an old technique, which I think is, but I put it in because I want to discuss some of the modern techniques for looking at genetics now and what we can do in the laboratory. But this is what I think is a beautiful picture of some nuclei which have been stained, and the chromosomes have all been labeled with different colors. And you can see that this is a normal nuclei. But when we look at glioblastoma, we can see that the chromosomes are highly disorganized. And in fact, what happens in glioblastoma is that the genome is duplicated and they get gains and losses of chromosomes. So there's very great genetic change. And this actually contributes to the resistance of the tumors to treatment. So we often saw trials at ASCO with phase 2 data is promising, but then fails to deliver at phase 3. And I think that's because we were focusing on small molecule inhibitors. So focusing on a particular target like epidermal growth factor receptor, it doesn't work for this tumor type, unfortunately, because these tumors escape those treatments. The biology of glioblastoma is still not well understood. However, I think it is rapidly improving. This is a trial that had some success and is actually at the moment going for registration. And it's an immunotherapy trial with a treatment called dendritic cell vaccination. It was with a company called DCVax. The trial randomized 331 patients internationally. We were part of the study. It was a very interesting study to be involved with. The patients required to have surgery. And for us, we had to arrange the surgery first thing in the morning. And then the tumor material had to be shipped to Germany fresh. So we had to be taken to the airport and taken to Germany fresh. And then they manufactured the vaccine by taking monocytes from the patients and mixing it with the tumor material and then maturing the monocytes up to dendritic cells. We then got the dendritic cells back, they were frozen, and we injected them back into the patient. Now, what's interesting with this study is that there is a signal of response. And in particular, there's a marker of response in glioblastoma, and it's called a gene called MGMT, and whether it's switched on or switched off, so whether it's methylated or unmethylated. And what we can see for those patients where the gene is switched off and they've got a methylated MGMT, that there's a survival advantage with the dendritic cell therapy. There is a small advantage with the unmethylated group, but the majority of the advantage comes with the methylated. And that's something just to bear in mind and something we need to think about. There were discussions around Can you cross the blood-brain barrier? What are the issues? And what we can see is from the dendritic cell therapy study here, we can see some pre and post-vaccine biopsy material, and we can see post-vaccine that there's infiltration of T cells in the tumors, which will have been induced by the dendritic cell therapy. So we know that the barrier for the blood-brain barrier is not an issue in this case. This is another immunotherapy. This is a study that we did with a drug called nivolumab, PD-1 inhibitor. So it's a checkpoint. It's more straightforward because you can just get the nivolumab off the shelf. And in this study, it was an international study that we were fortunate to be part of. And patients were randomized to receive bevacizumab, another antibody, or nivolumab, the PD-1 inhibitor. And what we can see is that those patients who had methylated MGMT had some response to the treatment. But also importantly, these were patients who were not on steroids. So that's something else for us to think about. So we're thinking about the status of the immune system. So it's important about being on steroids or not being on steroids, and also this methylation of MGMT. Now, if you think back to the slide I showed earlier with the chromosomes, what this is now showing is this is where we can take tumors, and these slides were prepared by one of the bioinformatics people in the laboratory, Ben Kinnersley. And what we can see is that when you take a tumor and you separate it, you can see and label all the cells, and we can now count individual cells. And when we actually look at the normal brain tissue, you can see the representation of the cells there. And when we look at a glioblastoma, what we actually see is that there are some of the cells, in fact, a fraction of the cells are glioblastoma. The rest of the cells are myeloid cells and also lymphocytes. So what we're seeing is that these tumors are not just all one body of tumor cells. It's an inflammatory disease. And within that inflammation, there are cells which are protecting the tumor cells. And at the same time, there are cells which are fighting the tumor cells. So what we need to think about is how do we change the balance of those cells within the tumor to give the body a chance to kill the tumor. This is another method. This is called spatial transcriptomics. And why this is so important is you can take a slide, a paraffin slide, and you can label the cells on the slide. And rather than the previous slide, which shows single cell analysis, what this does is this allows down to single cell data, but it tells you the relationship between cells in the tumor. And that's really interesting because it's going to tell us how the tumor cells are surrounded and what immediate cells are around and protecting them. This is a technique which we're doing in the laboratory, and it's in its infancy, but I think that we're getting to the level of detail now that we'll be able to incorporate these techniques into clinical trials to help us understand what's happening. So just going back to our electro-hypothermia experience, we had the first EHY 2030 delivered into the UK, and I started using it in January 2023. We had all the regulatory approvals in the UK to use it. We've also had approval from UCL and also from UCLH, the hospital, that we can use this device in clinical trials. So far, I've treated 27 patients. My experience of using the machine has been an absolute joy. We have seen partial responses in patients, which is very unusual for glioblastoma. The treatment is extremely well tolerated. The survival data, we're monitoring it. I'm not going to show it today because it's too immature, but I have to say the results so far are extremely encouraging. I show one example here, which Balas showed earlier, which is the second patient we treated had a response within a few months of treatment, which we were very excited about. And we have seen further responses since that time. What we'd like to see now is how durable those responses are. But I have to say we are greatly encouraged. So we have a clinical trial which has been opened at UCLH, and I'm telling you about the trial because we are going to be combining this with the Oncotherm hypothermia. And that is the beauty of the hypothermia device, is that you can combine it with many treatments. So this particular trial is of a drug, which is a PARP inhibitor, which is labeled with I123 iodine. And what happens with these patients, it's for recurrent glioblastoma. The surgeon will go in, take out some of the tumor to make a hole. They won't be able to take out all the tumor. They're going to put an Ommaya reservoir, which is a tube, which fits under the skin. And then we're going to inject the drug directly into the tumor. So this is a phase 1 trial. And once we reach our recommended phase 2 dose, the plan is that we're going to then combine this treatment with other treatments. And one of those is with electro-hypothermia. And those discussions have taken place. The trial protocol is in place for us to do that. So the other studies that we are doing is we are going to do a feasibility phase 2 study of standard of care plus electro-hypothermia. And I know that it's safe and it's feasible, but I need to demonstrate to the regulatory authorities, to the university, to my colleagues in the UK, that this is a safe and feasible treatment. So we're doing a small feasibility phase 2, which is being run through UCL and sponsored by UCL. We're also doing a feasibility phase 2 of a checkpoint inhibitor. We've done others, and we've previously done a trial of giving immunotherapy prior to surgery. And we had some success there, and we're building on that success with this checkpoint inhibitor study. And the reason I'm telling you that is because following these 2 initial studies, we're going to do a study of a combination of the checkpoint plus electro-hypothermia. So we have in place the Citadel study plus electro-hypothermia, and we're going to have our checkpoint plus electro-hypothermia study. So what we're actually doing in the laboratory is that we're using window studies. We've designed it as a window studies so that the patients will have a biopsy, they'll then have treatment, and they'll then have surgery, so that we've got pre and post treatment samples. And in the laboratory, we can do the single cell analysis, and we can also do the spatial transcriptomics. And that will help us understand what's happening to the tumors when we treat them. So just thank you for your time. I just want to say glioblastoma is a very challenging area to treat. We've learned an awful lot about treating it, that targeted therapies have not been effective. We've seen some benefit with immunotherapy, and I'm very excited at the prospect of seeing an enhanced responses to immunotherapy in combination with the electro-hypothermia. But what we need to do is we need to do these in clinical trials, and we have a program of trials in place so that we can test these. Thank you very much. If anyone's got any questions, I'd be happy to take them.
That was Dr. Paul Mulholland, MD. We'd like to thank you for a very educational and very informative deliberation. Any questions from the floor?
Killian? Anyway, just a quick question for the group based on the specialty of Dr.
Paul.
There is a patient who just emailed me. He is a 26-year-old male with diffuse midline glioma, IDH wild, H3, F3A, mutated MGMT, non-methylated, with a diagnosis of diffuse midline glioma, IDH wild, H3, F3A, mutated. He was asking if the Oncothermia could be used for this for this case. He underwent left ventricular shunting after on February 20, 2024, and oral chemotherapy already on cycle 6. And if the good doctor would give us an advice, he was asking if he could use this, and what results would he expect?
These are histone mutant tumors. I think I don't have experience of treating those with the electro-hypothermia, although if patients do come to me, I would treat them. He has a shunt in place. We've treated one patient who has a shunt in place, and we haven't had any problems with it. I would be interested in hearing the experience of others about treating patients with a shunt. The only thing that I would say is with the location of the tumor, you do have to be a bit careful about hydrocephalus if they are at risk of hydrocephalus, but as he has a shunt in place, it shouldn't be an issue.
Okay. Thank you, doctor.